Välkomna till Sveriges första transplantationsforum. Ett forum tillsammans med vårdprofession, patientrepresentanter, life science-företag och akademi och överhuvudtaget alla som är intresserade idag av transplantation och organdonation. Jag heter Penilla Gunther, jag är grundare av en mötesplats för just alla de här intressenterna som heter FOKUS patient. Och vi är jätteglada att ni ville komma hit idag. Och vi har haft 2 dagar tidigare här nu, måndag, tisdag, där den ena konferensen handlat om patientsäkerhet och den andra dagen om ett CVD-forumet om kardiovaskulära sjukdomar. Och idag så har vi då äntligen det här transplantationsforumet. Och jag ska lämna över ordet till en av våra samarbetspartners här, Håkan Hedman från organisationen Livet som Gåva. Varsågod.
Ja, tack så mycket Penilla här. Då som en av samarbetspartnerna till den här konferensen så vill jag också passa på att hälsa alla hjärtligt välkomna. Jag vill också passa på att tacka Penilla Gunther för initiativet med den här konferensen. Vi har pratat länge i vår styrelse, i Livet som Gåvas styrelse, och nu blev det äntligen av som sagt var. Och det tycker jag var ett väldigt bra initiativ att vi kan samla alla i det här nätverket som rör organtransplantationer, både patientorganisationer och profession samtidigt. Jättefint, bra initiativ här. Och jag tycker också att jag har fått ihop ett väldigt intressant program med många intressanta föreläsare både från Sverige och ifrån utlandet. Här. Jag är ju själv njurtransplanterad sedan 37 år tillbaka. Är det faktiskt i år. 1985 fick jag min njure och det är samma njure. Så att jag vet ju faktiskt verkligen betydelsen av organdonationer och naturligtvis vad en organtransplantation innebär för en person. Det är tack vare den som jag kan stå här idag och prata. Så att jag vill återigen hälsa er hjärtligt välkomna och hoppas att ni får en intressant dag tillsammans allihopa.
Tack så mycket Håkan. Vi ska också nämna att du är ordförande i Njurförbundet.
Ja, det sa jag aldrig, nej. Ja.
We are also very, very proud and honored to have a lot of distinguished guests with us today, and one of our collaboration partners beside Livet som Gåva is also ISHLT, European Society of Organ Transplantation. So very, very grateful for all these collaboration this week that we have had for FOKUS patient conferences. So now we leave the floor to Hanna Brodda, who will moderate a conversation with our guest via link from the World Health Organization in Switzerland.
Yes.
Okay.
I hope so. He's going to show up here any minute, but how are you today?
Jag går ner här.
You good? Mm? Good. Yeah, we had some lovely days actually. 3 days in a row, and this is the last day, and it's going to be a very interesting program, as you say. Yeah. My name is Hanna Brodda, and I'm a journalist, and we're going to have Stratos CHATZIXIROS here from Geneva. Mm-hmm. Hello! Hi!
Hello. Good morning. Hello,
Good
everyone.
Morning. Great to have you here. Yeah, Stratos is the advisor of Transplant for the World Health Organization, and you're going to give us a short presentation on the overview over the situation with the organ transplants and the supply for the world and how the situation looks. Right?
Yes.
Great to have you here. Thank you.
Well, thank you very much. And I'm sorry I was not able to attend the meeting in person. And I hope there will be another opportunity at some point in the near future, actually, to be able to be with you in person. Thank you for, again, I will try to give you a brief introduction. I suppose a lot of things will be covered later on the agenda. So this is from the perspective of the World Health Organization and the global issues around transplantation, donation and transplantation. And let me start by saying that we're referring to products of human origin in general. So it's not, we go beyond organs, there's tissues, cells, blood, anything that derives from the human body and is destined to the human body again for treating patients. And we know that these are have an exceptional nature. This what we call medical products of human origin. In the European context, they are called also substances of human origin. You'll find these different terms, SOHO and MPHO. And they can save lives. We know that they can prolong life, reduce the morbidity, and improve the quality of life. However, there are certain challenges because they're not just medical treatments as any other drugs or surgical interventions. There's a lot of ethics behind them because they come from human beings, sometimes live human beings, and deceased, of course. Safety issues when it comes to the transmission of diseases from one person to another, their manipulation to make them viable, their quality, and of course all these risks. And then it comes to the different regulatory frameworks and oversight that is also fragmented in many countries. So from the World Health Organization, as early as in the 80s, well, late 80s, early 90s, the World Health Assembly, the member states actually requested to develop some frameworks, some guiding principles on how to manage the donation and transplantation. So you can see a list of resolutions that were provided in various years, the last being in 2010. And the baseline of all these resolutions is to, as I said, develop guiding principles, ethical frameworks, which highlight the issue of respect of the dignity of the donors and the recipients, the voluntary donation, and the non-remuneration, the autonomous and free consent to make decisions, of course, to protect the vulnerable person from exploitations and the privacy and transparency, and all these issues related to the donation. Of course, we need to look into the operational aspects like optimizing the risk and benefits of safety, surveillance that are needed, reporting systems to collect the data and monitor, and of course, last but not least, to ensure the equitable access to those treatments, and of course, to avoid any form of trafficking or commercialization. So this is an overview of those 11 principles that are related to transplantation. And I've put them in groups, as you see, related to the donor, related to the process, and related to the recipients. And I would like to highlight, as I said, it's about consent, about the diagnosis of death in order to have organs, the protection of the live donor. There's a specific principle that highlights the issue of maximizing deceased donation in order to provide more organs and of course to avoid the exploitation and risk of live donors, and of course to protect the vulnerable people and the competent and the vulnerable from being exploited, and to promote the voluntary form and non-remuneration of the donation. And of course, the equitable allocation that I just mentioned before. So this is more or less what was in those guiding principles, and then comes the resolution asking member states to take certain measures in order to implement those principles. And this is sort of the mandate that we gave back to the member states, to the governments, on what they needed to do. So from a system perspective, in order to develop the legislative frameworks in order to regulate and cover the operations. So you see, they have to promote the altruistic donation, they have to oppose the seeking of financial gains. These are all things that need to be embedded in the legal frameworks of the countries, but also they need to establish authorities on oversight to collect the data, to monitor the activities, and of course, to provide access to the patients through welfare, social security, and all the relevant aspects of a national health system. So you see, what you need to consider, the governments need to consider in order to implement transplantation programs is to have, first of all, as I said, the legislative frameworks. They need to have the policy and strategic planning in order to invest certain resources. This means the financial sustainability is very important. Of course, you need workforce that will need to be dedicated to that. You need infrastructure, hospitals, you have access to drugs and other surgical and non-surgical interventions, diagnostics, and all these things that are costly. Then you need the systems to trace what is happening, the oversight, which is also linked to the vigilance and surveillance aspects, which is for the safety of adverse events and reactions. The transparency is very important because this would lead to public engagement. The public engagement, again, is building trust. It's not just raising the awareness of the public for the donation, but it's also, as I said, being transparent means that they have access to information, they know what is happening, and they understand, and they can participate in that. And what we've learned also from the recent COVID situation, you need to have crisis response plans in place in order to be able to cover when it comes to lack of access or lack of availability of products. So just to summarize, we call governments to have self-sufficiency in transplantation, in donation and transplantation. So this is just a schematic approach again to say that, well, by self-sufficiency, it means that they have to invest in their local resources. They have to look into what are their needs, first of all, in terms of diseases, like chronic kidney diseases, cardiovascular diseases, all these issues that could lead to transplantation, to avoid the progress of those diseases as a prevention measure, to invest in building a system, education of the society, vaccination, screening of the population, and of course to raise the awareness, but also to build the capacities in terms of legislation, data, and everything that I just mentioned before. National self-sufficiency does not exclude the cooperation between countries, because we do not expect every country to be able to sustain something on their own. So this is quite obvious in a global setting that you need to cooperate between countries. And there are very good examples in that, either by sharing waiting lists and resources, or by training and building capacity and sharing experience. So we see the progress of diseases, and especially kidney disease is a burden, is huge burden for the countries. Non-communicable diseases overall are on the rise, and they are very costly, and not just in terms of money, but also in terms of lives. And as I said, it's not just kidney diseases. We have all these non-communicable diseases that are on the rise, and other predominant risk factors like obesity, hypertension, that cause organ failure, and transplantation, therefore, is the optimal treatment. There are other treatments, and we need to compare them when it comes with transplantation in terms of their quality and their cost effectiveness. This is just to show you what is happening around the world. This is the latest data that we collect from a global observatory, and I'd like to thank the government of Spain for that support that they have in that project. You see the global number. This is in 2020. After you see the impact of COVID, also there was about an 18% decrease in activities, and we're more or less around 150,000 solid organ transplants global. But this is estimated to cover very little, 10 to 15% of the global needs of transplantation, and therefore we need to look into the different organs also. Also, we see that there's a huge difference also in the availability of transplantation in the organization, the legislative frameworks, you see about 34% of the global of the countries have any transparent system and organization and specific criteria for the patients and the allocation. So this is a global issue indeed, and we're very slow in the implementation. And of course, you see the differences also very visible here on the map, how between the regions we have huge differences in the availability of transplantation. And this is when it comes to the donation also, you see from deceased donation, which is, as I said, the preferred mode of donation that WHO would like to promote. You see also that only 38 to 40% of the member states report having available capacity for deceased donation. And these results, you see the differences also between the regions here, between live and deceased donors, and you see regions that are completely depending on live donation. That leads to having mostly kidney transplantation as a system. Of course, when it comes to other organs which cannot be procured from live donors like heart transplants, you see huge differences also between the countries that do have these programs. So it's a very challenging issue. And here is also to see that the availability, as I said, of those programs. You can see the numbers of centers per million population, and there are huge, again, differences between the regions in the availability of programs. All this leads this is to understand also that countries have, as I said, slowly invested in transplantation. You see the differences between dialysis and transplantation, kidney transplantation throughout the years, that more money have been going into renal dialysis rather than transplantation, especially in those countries that are developing and they have the resources now to invest, and they choose to not do so in transplantation. All that, as I said, the lack of availability and lack of access would lead people, which are desperate, of course, we understand people want to live, they would lead them to seek another way of having a transplantation. So they travel abroad to wherever possible. That might result also to unethical practices in buying organs from other desperate people who are also facing issues of poverty, of social exclusion, like refugees, migrants, illiterate people in many countries that are being exploited as source of organs. So you see the exchange between all the regions. People travel everywhere, and this is very difficult to monitor. These are very few numbers that we have been able to collect, because even the member states do not have this kind of registration and understanding of what is going on when it comes to tourism. And this is just some more data from the European region specifically, since we are hosted there today. And you see from the Council of Europe exercises also that many people would be traveling within the region also. And it's justifiable in some cases. You see big numbers like Bulgaria, Greece, you see on that slide. We happen to know that these countries have some bilateral agreements with other countries like Austria for lung programs, because they do not have the capacity in their country to sustain a lung program. So therefore, they have an exchange of patients and grafts. And this is justifiable, and this is what we are promoting, the bilateral agreements, in order to complete and fulfill the needs of the patients and to be under a legalized ethical framework. So to conclude, this transplant tourism, as I said, issue is linked to the lack of availability, lack of access to transplantation, and we need to reinforce the systems in order to deal with that problem. And unfortunately, the demand surpasses the availability of organs. Conclusion that we see a very slow development of transplantation worldwide, and I'll just mention again, very low rates of disease donation. 40% of the member states only have developed that. Dependency on live donors is very crucial because it excludes other organs like heart, lungs, and also tissues, which I have not referred to, other types of transplantations, tissues or cells, all the ethical breaches that are related to the lack of availability and access, like transplant tourism, and of course the reduced government involvement in many cases. So to finish my presentation, we need to improve access to transplantation, and this has to be looked into from different aspects, because it includes financial, governmental, and societal factors. Society will play a major role, not just in supporting, raising the awareness of society for donation, but also in patient groups in order to demand the transplantation to be included in the national health systems and to be relevant policies to develop transplantation. and access. So lower income countries need to be supported, again, to develop that in terms of infrastructure, workforce, and various other aspects. High income countries also face problems. We've seen in that map discrepancies between European countries, mostly, I would say, struggling with organizational aspects, but also with awareness in the population. And as a consequence, of course, millions of recipients will travel around the world and will never be able to manage these black market and illegal activities. Therefore, I will close, and I would like to thank the organizers, specifically Penilla, for bringing me to that symposium, your forum, and such efforts. I have to highlight that this is perhaps the first time I speak globally to a patient group, and I'm very grateful for that, and would like to have more engagement and cooperation in the future. Thank you very much for your attention, and I would like to continue with questions if you have. Back to you, Hanna.
Great. Thank you, Stratos. Very interesting. Do you have any questions? You can just raise your hand. Yes, we have one question here, and you can have a microphone.
Thank you so much. Thank you so much, Stratos. You won't be able to see me. I just figured. My name is Turid Karlsson, and I'm working for a company named Deviser. We are a bit worried about the fact that after a solid organ transplant, we believe there is a little too little done to make sure that the transplant is actually staying, not being rejected. Do you have any comments to that from your position?
Yes, thank you very much. Interesting question. Indeed, we've seen in some countries, even in very rich countries, if I may say, that the health system is providing follow-up care, medical care insurance for medication only for like a few years. And this, of course, results into the rejection because a lot of people may not be able to cover those expenses. Unfortunately, this is built on health economics, and it depends on the structure of the health system overall. So you have privatized systems, and what we are suggesting as WHO, universal health coverage as the basic principal element of all health systems, and of course, make medication, immunosuppressive drugs, and follow-up care as a necessary part of the transplantation package, and not just look into the surgical, or post-op care, but in a long-term aspect. We have to engage with countries more or less into convincing them, so we need all the stakeholders like yourself and your companies to promote that. Thank you very much.
So much for that. We're looking forward to the future.
You told us about so many areas where you work at the moment. Where do you, as World Health Organization, where do you put your most effort at the moment? Where do you think would make the most differences for people who needs organs and donors or potentially donors?
So we're trying to develop a global framework anyway to increase, as I said, all regions. But then, as you've seen in the map, those gray areas where we have a zero capacity. So those low income or middle income countries need to be supported. Otherwise, we're failing to reach our objective of bringing everyone on board and saving more lives. I think this will be one of the key issues and focus now. Africa region, South Asia region are our priorities. And there's been a regional plan also for the Latin American countries, which are in between more or less. They have some developed systems, but there has been a specific regional strategy developed in the recent years.
Let me know if you want to ask something. I have one question. It's of course this is one thing, organs crossing the borders between nations. But which country is doing the best? Maybe it's it's a bit in the future that there is not so many people yet traveling for organ donations. But which country is the best in transplants?
So statistically, that would be Spain, which has been highlighted as a world leader. We have a few countries in the top. So Spain, the US, and then followed by other European countries, Croatia, Portugal, Slovenia specifically is doing great in heart transplants. So there's a variety, mostly in the European and North American context. So the problem is that travel, as you said, the borders, if I may say, are closed to other people. They cannot just travel to a country. They have to be residents in order to get access to the waiting list or to have certain agreements between countries in order to reach those systems. Again, they are the best, but they have to be also supported through agreements because the donation comes from those local populations. You cannot put the burden of the whole world on a certain community.
Mm. What do they do in Spain, for example? What do they do? How come they are the world leader in transplants?
Well, Spain has started very early back in the 80s with organizing the system. It's not about the social awareness. This came sort of later, if I may say. It's more about putting the resources in organizing a system of detection of any potential donor, in identifying a potential donor within the ICU, the intensive care units, that suffers a brain damage, and therefore to actively pursue transforming that patient from a deceased to a donor with transplant coordinators in the hospitals that are trained in order to do that, intensive care doctors, psychologists that train, also family approach and all this. So an actively engagement in a donation system through quality operations within the hospitals. This is the key of the Spanish model.
Mm. So all the way from governmental and legal issues all the way down to the people working actually at the floor, yeah. Mm.
The whole system is financed by the savings that transplantation, especially kidney transplantation, generates, savings from dialysis. There's huge savings, and all this money goes back to the health system in support of other organs as well in their development. So hospitals are financed by the government. There's universal health coverage, free access to every citizen for transplantation.
Mm. Yeah, interesting. Yeah, we can learn from that here in Sweden too, and in Europe. Yeah, we have one question here.
Yeah, it's not really a question. I would just say that it's not only the question. It's not only the question of going from one country to another, but it's also the distribution within one country. And Sweden has not been all too good before at that point. And in that respect, Norway is a very good example, where they send organs from north to south to east to west very easily. So this is also something we have to work with. Thank you.
Well, this depends on the number of centers in the country and the programs, and of course on the logistics of sending an organ around. But just to highlight, within Europe, there is a program of exchange of organs, not patients going to another country, but exchange of surplus organs from one country to another. So if you're procuring, let's say, 8 organs from a donor, and you're not going to use a heart or a liver, or lungs, then you might be able to offer them to another country through a platform that has been developed by the European Commission. So not wasting the organs is also a key issue.
Yeah, of course, not wasting the organs, that's important. Okay, we have to continue the program for today. We're not going to be late. So I'm sorry, you can't. You will have to email him, Stratos, right? You can.
I'll be back at the end of the session on the panel, so maybe we'll have more chances to discuss later.
Great, so save your question for that. Thank you, Stratos, very much.
Thank you very much.
Delighted to have you here. Thank you.
Thank you so much, Hanna. And we'll continue with an exciting guest speaker. And we're very proud to introduce Andreas Zuckermann, who is the president of International Society of Heart and Lung Transplantation. So the floor is yours, Andreas.
Thank you very much. I just have to start my presentation. Okay. Now I need a technician, which is unusual for a surgeon. I put on. Now will we do everything? Because I put here to start this.
It's a warning of you.
A warning about me. Yeah, it's. I have to warn you about me. So I have a very clear. I have to disclosure. So I'm a cardiac surgeon, and I'm the director of cardiac transplantation at the Medical University of Vienna. So cardiac surgeons are very difficult people. Diplomatically, I'm right now the president of the International Society for Heart and Lung Transplantation.
So you start, and one of the house technicians will sort things out.
We'll sort things out. Okay, wonderful. So I'm used also to talk without slides. The topic, which hopefully will show up at some point, is the future for transplantation and ISHLT's global commitment for the future with our core competencies and core values. So this is a little bit a divided talk about, first to give you a glimpse into what's going on in cardiac transplantation, what the future will bring. Of course, through the lens of a cardiac transplant expert, because if I would start to speak about liver, kidney, and lungs, and pancreas, and other organs, then we will sit here for the next 15 hours or so. So, of course, I have to tell you, I'm focusing on cardiac transplantation, and then I bring up a little bit what an international society, a scientific society, can do, what is their share to improve results and outcomes after transplantation. So of course I have disclosures. I'm also working and doing a lot of science with different companies. So the main topic is the burden of heart failure. This is a deadly disease in all its aspects, and this is increasing. This is data of the US. I found that the better slides for the US right now. So this is an increasing number of people who really have to live with heart failure, and the burden of heart failure has a huge economic impact in direct costs, which means people have to go to the hospital and receive treatment, but also indirect costs, which means that people have to go out of work and cannot work anymore, and the society has to pay for them pension or unable to work. And the numbers are rising. This is data from 2013, and it's pretty clear we're now in the mid-2020s, and these American as well as European data are significantly increasing. And this is a recent summary by the European Society of Cardiology that you have 1 to 3% of the general adult population are have the problem of this disease. So the overall prevalence is rising. The incidence 1 to 20 cases per 1,000 patient years per 1,000 population. So these are complex statistical methods, but it's clearly saying this is a disease that really hits us everywhere on the globe, but especially, let's say, in the high economic countries. And although mortality, well, 30-day mortality is pretty low, the burden of the disease is that with heart failure, completely underestimated. A lot of people die within the first 5 years. If you compare that to different kinds of cancer, you're in the upper field. So heart failure really is as deadly as some of the cancers that hit our population. And again, cost drivers are there. It is a huge burden on our economics everywhere around the world. So let's say for advanced heart failure, the last stage of heart failure where you do not have any other treatment than to transplant the patient, it really depends where you are living in Europe. You heard about by our WHO speaker what are the transplant numbers in Europe, and this is the numbers of cardiac transplantation per million population, and if you're lucky enough, and this is older data, and I will compare it to newer data. So these were the top performers in heart transplantation. transplantation. We already heard Slovenia, Croatia, but also Austria and the Czech Republic were part of that, and France. And then you had, I would say, the upper middle pack, where also Spain is part and Sweden is part. Then you have lower numbers like Italy or Denmark. And then you have a huge number of countries in Europe and close to Europe in the Middle East where either no cardiac transplantations are performed or at a very low rate. And there are some big countries like Germany or the United Kingdom where you have a very low rate of transplantation overall. But comparing that to last year, and this is the newest report by EDQM, it's a Council of Europe organization, the Transplant Newsletter, well, there are only 2 countries left with this high number of transplants per million population, Croatia and Slovenia. And unfortunately, Austria, France, and the Czech Republic really went down in the numbers, partly due to the pandemic, but partly due to other reasons. Some of the countries like Poland, fortunately, increased their numbers, but also Sweden is stable at 6.5 per million population. And still, you have a lot of these yellows and still no change. Very low numbers and a huge number of centers and countries around Europe. So this is still a problem. And this has a direct impact on the waiting lists. You can see we never can solve the demand of the waiting. This is Eurotransplant data. So you have every year there are more than 1,000 patients are put on the waiting list. And even with our membership countries, we're really trying to achieve more transplant. We still are stable and just can serve about 50% of the patients every year. So this is a big problem for us. And looking at the outcome, and this is again Eurotransplant data, there might be some country-wise differences, but within 1 year, only 37% of the patients who are put on the waiting list receive a transplant, and 80% die on the waiting list. This is way too much, and we have to do better on that. So one of the questions for the future, is this the future of end-stage heart failure? We call it the rise of the machines. Will, instead of transplantation, we use mechanically assist devices to help these patients survive? Well, the good news is with the new technologies based on data from big studies, the outcome with patients with such an assist device has become significantly better than 5-6 years ago. So now it's almost up to 80% of survival with such a mechanically assist device for 5 years almost. So this is excellent data, but nevertheless, the quality of life still is not comparable to transplantation, but it's a march into the right direction. Concerning transplantation, well, actually, for a cardiac surgeon, it's a simple standard surgery. Bypass surgery is more complicated. The big problem about transplant, it's mostly in the night, and you have to be very fast because you have this ischemic time, because the heart does not function outside of the body for a very long time. So we train younger surgeons to do this because we want to sleep in the night. But there are also certain special cases like congenital heart disease with patients who had 5 cardiac surgeries before or have a mechanical assist device where the surgery becomes significantly more tricky. And in Europe, in complete contrast to the United States, you can see that the median donor age of those hearts that we accept has significantly increased. So whereas in the US it's quite stable around 25 to 30 years, in Europe it has risen. Question, why are there so much differences? Well, partly is because in Europe we have very strict gun laws, which is completely different in the US, and they have a high rate of gunshot wounds as potential donors, and the opioid crisis in the US is soaring, which leads to death in a lot of young patients, which is not in Europe. So we have to tackle that because we know that all the organ donors need special care. These donor hearts need to be better protection to make these hearts transplantable. So there are a lot of new technologies having already been tested and partly are therefore just using them as a routine way. And one of them, in Sweden, you can be proud, you have one company, Ex Vivo company, who is producing, and we are testing right now in Europe in a prospective randomized trial, the use of this machine, and so we'll see what the future will bring. But this is definitely something that might increase the number of organ donors, donations for cardiac transplantation, and might have an impact in better outcome after transplant. However, there's a price tag. This is no free lunch. These are expensive technologies, and the society has to be willing to pay this to support the patient population so we can increase the numbers of transplantation. A new potential way of organ donation, DCD, donation after circulatory death, which has been first successfully performed in the new era, 2014 in Australia, and several European countries leading with the United Kingdom, have performed this kind of special donation after circulatory death. And we in Austria also started a program in 2019. We did our first successful case and helped this patient who was extubated on the next day and could leave ICU pretty fast. So I think this is a very important new way of organ donation that might help us increase transplant numbers in the future. Of course, concerning immunosuppression, well, right now we still have to use immunosuppression in all of our patients after transplantation, and there is always this balance over versus under immunosuppression, and we have to learn the sweet spot to find the right balance between over and under immunosuppression in our patients. But the problem is, these drugs are strong drugs, and all of them, no matter what you use, no matter what combination, and I just put the names of the complications and just the short names of these drugs, we produce collateral damage. And this is where we have to do a better job to really find out how much immunosuppression each patient will need. Because they're still, I call them the 4 apocalyptic riders of long transplant outcome. There's always infection on the horizon. You always have to be careful. And of course, some of these drugs produce renal insufficiency, renal failure, cancer development, also developments, cardiovascular disease, and we have to tackle that. And on the other hand, and this, as you know, is the most famous Austrian, the Governator, Arnold Schwarzenegger. I just show this picture because our problem is aging. We, as doctors, are partly the slaves of our success. We have become much better than in the 80s, so our patients survive significantly longer than they used to do in the 80s, but we also transplant older patients. And age has an impact on kidney function. It has an impact on lung function, on liver function, gastrointestinal function, vascular function. No matter if you're transplanted or not, it happens to all of us if we are aging. But it also has an impact on pharmacokinetics, so how the drugs are working in your body. And this has an impact on the side effects that really might have might develop faster or stronger in older patients. And we have to accept that even our superheroes in the youth, like Conan the Barbarian, in the end grow older. Well, this is a newer picture, and you can see, because our friend Arnold, he's a cardiac surgical patient. He received 2 cardiac surgeries and 1 TAVI that was put in here. So the problem is, where does the journey go? Well, right now the problem is there are no really new drugs on the horizon. And the drugs they were using are just generic. So the big companies who invested to build up these drugs, they now do not earn too much money with that. So the companies are not interested to do studies because studies are very expensive. And the problem is, and this is on us as doctors, we are missing transplant consortia of experts working together in a big group to develop important long-term trials, because the companies are not interested. And these trials cost money. So it's really hard to organize these transplant consortia to ask really important questions or endpoints that matter to patients. And I think this is really important, and we have to do a better job on that. This is, from my organization, the biggest registry in heart transplantation, the registry of the ISHLT, with way more than 100,000 patient data included. And you can see this significant improvement of survival, which is mainly seen due to better early outcome. Of course, on the long-term outcome, it seems to be quite parallel, so we have to work to do a better job in that. But having said that, and this is what I also wanted to ask the WHO, it's a provocative question, is we have very strong and very tight data protection laws in Europe right now that are very important, but it's really tough to work with international data, and we need big data to understand if we are doing good things to the patient or, let's say, less good things to a patient. And if we cannot connect with each other, then we are missing out the development of data. So we really have to find a balance between analysis of big data versus data protection for each individual person. And this is something where we really struggle and work and try to work with legal people to find a way to bring data together, to really analyze in a big way, because this is the only way to understand where the journey will go. And there's always a question I ask, do you think that all these patients or potential patients might need the same immunosuppression? Patient is in the intensive care unit prior to transplant, a young mother of 3 who might be immunological, more aggressive, an older patient, a pediatric patient, an obese patient, patient with a mechanical assist device, or a young patient who likes to skateboard more than to take drugs. Well, I strongly believe we do not need the same drug levels for every patient. And there's something we can learn from cancer treatment, where you move from a current one treatment fits all to a more individualized approach based on better diagnostics. And this is where I really want to take you into the future, and partly the future is starting to develop because we have new technologies to measure cell-free donor DNA. We have a new analysis to the molecular microscope, and then we have found that some non-pathological virus start to replicate stronger if patients are immunosuppressed. So this might be the first time that we could see how much immunosuppression level a patient really is in when we give the drugs, because a patient might react differently than another patient. And I think not one of these tests will be the gold thing. I think it has to be a complicated coordination between the tests, and we have to understand that better. So we are in the learning process in doing that, and hopefully we can help the next generation of patients. And I always want to thank all the patients who participate in studies. And when I ask them, why do you participate in this study? And they said, well, I want other patients who go into this problem 10 years from now to already have a better chance on long-term outcome. And I think this is a very altruistic approach, and I always thank these patients for that. Excuse me. So where is the future of heart transplantation or overall transplantation? Well, maybe do not care about blood groups anymore, just transplant across blood groups. Immune tolerance induction, so we do not need any drugs anymore. De- and recellularization of tissue and hearts, or 3D bioprinting or xenotransplantation, using animal organs, modified animal organs for humans. Well, concerning 3D printing, an Israeli group already produced personalized, thick and perfusible cardiac patches and hearts. They are still not functionable, but this is a first step that they really mimic the real structure of a heart on its microvascular situation. I think this is a very promising and interesting way for the future. And one of the European top groups in xenotransplantation is the Munich group, and they laid path for, in the end, the first world xenotransplantation, which was in the beginning said as a huge success, and then in the end a failure. So they have to go back to the scientific field and work more. But definitely this is something that might come up in the next 5 years as a routine treatment for patients in dire need of a donor organ. So with that, the next point, of course, is the ISHLT. What has the ISHLT to do with that? Well, we are a non-profit, multidisciplinary professional organization dedicated to improving the care of patients with advanced heart or lung disease through transplantation, mechanical support, and innovative therapies via research, education, and advocacy. Very nice mission statement. So what we're really doing, so that we are very interdisciplinary. There are a lot of different pathologists, basic scientists, surgeons, cardiologists, infectious disease people, ethicists, trying to work in the different fields that we cover, like heart, lung disease, pulmonary vascular disease, and of course all the points of mechanical circulation. And we try to work with education, publications and research. So we have new ways to bring over education to other parts of the world. And we really put a very strong effort in supporting science, and we build up a foundation that is working which is independent but working for the ISHLT, building up grants, different grants for different areas of end-stage heart failure research, and we try to build up 6.5 million of US dollars that we put into research in the future. So in my job right now as the president is to go for the global outreach in education and advocacy, and last month was partly brutal. Across the world, I went to Bogota and trained cardiologists and surgeons there. I went to Seoul, went to Argentina, and very importantly at a meeting with the Eurotransplant leadership that the Eurotransplant data will be sent to the International Society of Heart and Lungs Transplant Registry to really improve the data, because we need the data from all these countries around the world to make this. And lastly, I think it's very important, transplantation is a team effort. It's not just us surgeons or cardiologists or whoever the specialty is. Dr. Shamway, who did the first experiments on heart transplantation, told his patients when they said, "You are the stars, and now you make us look good." It's just that if the patients have a good quality of life and outcome, this is what makes surgeons famous. But I don't think like that, and I think it's very important. I think this rising sun and helping patient climbing out of a real bad situation, getting back to normality, based on this young lady who was transplanted more than 30 years ago, and now even 30 years after transplantation, she has a good quality of life, and this is in front of the Imperial Palace of Austria. So thank you very much for your attention, and happy to take any question.
Vi har några minuter, så finns det några frågor snabbt så, och kort och koncist.
Thank you so much, Andreas. Turid, my name is, coming from Devisor. I have a million questions and suggestions and comments, so thank you so much, very interesting. One of the things that we are working with very actively now is to being able to diagnose before a rejection happens, so that you can make the immunosuppressive being where it should be, so to say. We're working with the biomarkers CCD, FDNA. We have a very low or high sensitivity. What if you were to wish, because you were talking about that puzzle, and I totally do agree, together with the doctors at KI that we're working with, that puzzle is not only that biomarker. What else would you like to see just on top of mind, apart from what we are doing already today, giving HLA types, antibiotics, so on and so forth?
So I think what would be very helpful is, let's say, a matching program where when we do the transplant to already know how well is the recipient matched to the donor organ, so we can assume what's the level of immunosuppression we might need. Where we know partly that younger patients need more immunosuppression, that most women need more immunosuppression, but they tend, if they were pregnant before, they tend to be a little bit more aggressive. So there are some factors that we know, but we do not know the level. And this is something which is really missing to see. So at what state is the transplantation? Is it high risk, low risk, medium risk of rejection? So we can start to level our immunosuppression to a certain way. We started a clinical study using actually an old technology, but used in a new form called photopheresis, where we would use it to lower immunosuppression overall in high-risk patients who are at high risk for infection, or patients who had cancer before transplantation, where we do not want to have high levels. And it worked pretty well. But we are missing, let's say, the marker, okay, go as it is, you can lower immunosuppression or you can increase immunosuppression on a broad scale. This is something where we really still struggle, because I strongly believe we over-immunosuppress 80% of our patients, and we think that we need significantly less, but we need stability and safety for us as doctors, so we would not harm a patient and just lowering the suppression.
So we are looking as well at the tight monitoring. How often, how frequent would you need to do the monitoring afterwards? And since the CFTNA wouldn't be invasive, possibly could it be a testing regimen shift?
Absolutely. We are open for everything that helps patients. I just know that patients hate to receive biopsies.
Sure.
So to get the needle in their neck, I would also hate this. Everything that you can find out with whatever other matters, and then put into a big computer and say, you're safe, and you might be safe for the next 3-4 weeks or 3-4 months. That would be perfect. I think it would also be perfect for the patients.
Okay, thank you so much. And I'm a very tough moderator today because we have plenty of interesting speakers today. So thank you so much, Andreas. I think we can offer a hand